In any event, if you do that and you let a rat self-administer cocaine intravenously, which they will readily do, they lever press like mad. They go nuts trying to get cocaine, but they're not getting any anymore. And the brain nucleus accumbens levels of dopamine plummet. So this is a kind of perfect kind of picture, if you will, in vivo picture of how the brain is changing just during a self-administration session. And the other reason we know that the nucleus accumbens is critical for cocaine, that the dopamine in the nucleus accumbens is critical for cocaine reward is we removed the dopamine from the nucleus accumbens. And the rats quit taking cocaine. Now you might ask, why don't we do that to people? And the answer is, they may lose a few other behaviors in the process of not having any dopamine in the nucleus accumbens. So I often tell the patients, so when does your nucleus accumbens dopamine normally fire? Well, what I tell the patients there is, if Brad Pitt walked into this room, every female in the room would orient toward that, and probably there'd be a few gasps, all right? And you would have a release of dopamine in your nucleus accumbens. Now, guys, you might not have that release to Brad Pitt, but if Angelina Jolie walked in the room, you'd probably go, ooh, and then you'd have a release of dopamine. But when you take cocaine, you have 10 times that release of dopamine, 10 Brad Pitts in one injection, right? And that's what we see in the previous slide, because you're getting an increase here of 400%. Opioid peptides have a key role, and they have a role in the nucleus accumbens, but also in other structures, one of which is the amygdala. And the amygdala, I remind you again, is in our temporal lobes. This is our temporal part of our temporal mandibulum. So the temporal lobe is this part of our brain, just under your ears. And deep in that area is a structure called the amygdala, long known to be involved in hedonic processing and how we associate rewards in the environment. So I'm going to switch to alcohol now and just show you that we can also train rats to drink alcohol. We start them on wine coolers, just like people. And the rats don't like alcohol that much, not at 10%, but if you put them on a wine cooler, then they'll drink it readily. And then we take out the sugar and just have them, they have a bar-like situation. They mix their own drinks. They press their two levers. They can get 10% alcohol or water. You can see their blood alcohol levels. It's equivalent to about a glass of wine. We do it at night when they're normally active, so and they get 30 minutes. That's it, 30 minutes. But if you do this and then you start asking the question, well, what mediates the reinforcing effects of alcohol? You can do studies like this that we did, and this is just an example, where we micro-injected an opiate antagonist, an analog of naltrexone, into the nucleus accumbens and also into the amygdala. What you can see on this slide is that we can dose-dependently block ethanol self-administration in non-dependent animals. These are social drinkers, if you will. But we get a pretty powerful effect, especially in the amygdala. And these are effects that are very similar to what we see with heroin, if we were doing heroin self-administration. So the bottom line is that there are multiple structures involved in the reinforcing effects of drugs. All right, now we're going to pass to the dark side. So this is a Guyasamin. This is a painter in Ecuador who painted the plight of Native Americans there. I like this painting because it shows a light side of the face and a dark side of the face. But now we're going to move to the dark side of addiction. And we're going to focus on the same VS, the nucleus accumbens, but we notice the color has changed. And that's important because I'm going to argue that the motivational state has changed. And then the amygdala you'll see also in red now, and that has a key role in these effects. So all of you know what withdrawal is. There's this famous designation that's in all the medical textbooks of physical withdrawal and psychic withdrawal. I don't like the distinction, frankly, because I don't think somatic or physical withdrawal has a whole lot to do with addiction. I don't think people take alcohol because they have tremor, all right? I don't think people take opiates because they have goosebumps. I think they take alcohol and opiates because they're miserable, right, when they don't. And so we call those motivational signs, and that's what I stick with. And the motivational signs of withdrawal, basically, it's what I call the misery factor, all right? And the misery factor is something that has a strong basis in psychology and physiology because it's the opposite of what the drug does initially. And so on the left-hand panel here, this comes from Richard Solomon, you have, he was arguing for heroin back in those days, but the initial response, the A process, is pleasurable. It's hedonic. It feels good. You're getting high. And afterward, there's a little afterburn, like a hangover, but nothing really dramatic. But if you become dependent on heroin, you lose the A process, or a lot of it. That's called tolerance. And you gain the B process. And there are a lot of us who think that the B process actually subtracts out the A process, and that's how you get the tolerance. And I don't want to spend more time on it, but I just want to remind you that this is a common phenomenon. And I don't know whether you ever sat around at night thinking about, how does this occur? How do we get tolerant to a drug? And how do we get withdrawal? Obviously, something has to change in our brains. Does it really happen? Well, yeah, it happens. This is a paper that came out in the height of the cocaine epidemic in the United States in the 80s by Robert Bick. And the straight line monotonically decreasing is cocaine levels in the blood. And the other diagram looks a lot like the A process and the B process here, right? And that's the hedonic response to cocaine. And this person was smoking crack, the equivalent of crack cocaine. It was coca paste. It was less pure, but in fact, probably delivering about the same, because if you know the nanograms of cocaine in the blood, you know that 400 nanograms per mil is a pretty high amount of cocaine. But the point of this slide is to show you that there is an opponent process, even in humans. Even with one injection of cocaine, the process begins. And if you look at the blood levels when the person's high, you can see that even after 40 minutes, even though the blood levels are still very high, the person is below baseline. They're actually showing a dysphoric response. And you can only figure that this gets worse with repeated injections. So what's a logical explanation for this B process, for this withdrawal, for this malaise with cocaine? Well, a logical explanation is maybe you depleted your dopamine system. Maybe your dopamine system's not working right anymore. Well, the data are pretty much incontrovertible that that's the case. So this is real human data from a real human patient. This is a slide that's been used so much it's almost iconic at this point. This is from Nora Volkow, who is the director of the National Institute on Drug Abuse, but it's been repeated dozens of times. And the top panel is indeed the nucleus accumbens and caudate nucleus of a human being who has never taken cocaine, and you see the red is very pronounced up there, and that means high dopamine. In this case, it's high dopamine D2 receptors. Person 1 month after abusing cocaine, there's less dopamine, dramatically so, and even 4 months later, it hasn't quite got back to normal. This data has been replicated numerous times in animal studies. We can see this when an animal binges on cocaine. I'm not going to show you slides, but we can see that dopamine is decreased in the nucleus accumbens during withdrawal. So one explanation for the opponent process, for withdrawal, and for the beginning of these severe changes in the brain that you all associate with addiction is the fact that you've lost function in your reinforcement system, your reward system. And that's the basis for my initial statement of the lecture, that addiction is a reward deficit disorder. You know, I can spend hours telling you later if you want all the details and papers that support this hypothesis, but this is becoming a predominant hypothesis in the field.